But first, do not abandon. So many people think if they opt out of things that they feel abandoned. And so I really, really want to stress that a lot, how important it is. That's the beginning of my title. First, do not abandon. So we're going to be looking at realistic treatment options and avoiding that overtreatment that people do not want or are not going to be beneficial for that. So I have 3 objectives that I'm hoping that we're going to cover today. The first one is to truly, what are some of the terms related to the non-beneficial treatment and things that we say that may not make sense to everybody. And then some of the issues that I identified in the perception of that abandonment, and then words that we can use to be supportive in communication regarding goals of care discussions. And it doesn't matter what level we're at. It isn't always about prognosis and diagnosis. It's about goals of care and are we all on the same page? This is one, I don't know a lot of, if you're familiar with this, but I spend a lot of time talking about, I call it the 4 C's: comfort, communication, choices, and control. If people are not comfortable, it's really hard to start a conversation. So I often will use what I call my Edmonton, well, I don't call, but it actually is an evidence-based tool, the ESAS, the Edmonton Symptom Assessment Scale, that goes over all these dimensions of where a person is. Anyone, a child can even use this as long as they understand the wording of it. But what goes, if you see the scale over on the right-hand side, from none to the worst, where is anybody on any given day? Everybody attending today, if you go through this, you might be able to put yourself at different areas with that. The ones we forget about are basically the last 4, the feeling of well-being. That means a lot to, it's going to be different for each one of us that are attending here today, but where it is. And sleeping, people often disregard sleep, but it's very important. Are you rested? Are you feeling your full self? And then financial and spiritual, those are all things that are often missed. We're thinking always so much physical, and it's important to include those things as well. And then the depression and the other things that are along that line. So the idea of non-beneficial treatment, though, is the idea that we often use value-laden words like too much or futile, inappropriate, disappropriate, stop treating, off of that. And we often will hear things like, there's nothing more I can do, and they're forgetting for the disease. We are humans. It's not just what we carry our burden on with that. And so our importance with that is respecting the individual as a whole person and making sure that those 4 C's are being met all the time. What we're finding, though, is up to 30% of treatment is unwanted and not necessary, not beneficial. And so are we offering it just because we can, or are we doing it with a good conversation with all of these things? Sentinel events, when Joint Commissions, we always think of death, but maybe death is actually, an outcome that we might anticipate. So we include all of these things that are palliative in nature, the human factors and leadership, our communication that's there, care planning, all of these different things. Because our ultimate goal is to decrease stress, have that good communication and trust that's there, and everybody, a win-win-win for patient, family, and clinical satisfaction. All the clinicians are feeling satisfied as well. So when we're talking about non-beneficial treatment, it's important to really talk about what does that mean. So the objective is that it's that intensity of the treatment and the expected degree. It's so that it's not, if it's not going to be just because we can offer it, our body may not respond appropriately to it. So if there's not reasonable hope of recovery or improvement, or permanently unable to have any experience for that person that's beneficial, it's not beneficial. Should we be offering it, and should we be doing it? So we often use the word futility or futile, but it's much better term to use non-beneficial, because that's where we want to be, because we want to always be able to offer comfort and care, because that's always possible, always. So all these interventions, we need to kind of ask these kind of questions. Is this intervention going to help? Is it going to obtain the benefit that we're doing? We always want to weigh the risks, benefits, and burdens and expected outcomes of what we're taking care of. And so in this scenario, is the risk outweighing it? Does the patient desire this? Just because we offer it, is this really what they want? Is this a reformed, consent, or are we going to get an informed, I don't want it? And have they been given that option? I often do not hear an opt out when I'm in any of these kind of conversations frequently. So we need to talk about that. And the clinical team, are we comfortable with providing that? Sometimes we say, this really isn't the best, but because we do that, and so sometimes we need to remove ourselves from this. I'm not comfortable with this. I'm going to transfer care to somebody that is more comfortable, especially the person that says, do everything, because it's such a powerful thing that goes on with it. So these are questions that we can tell our patients and families and residents, to really, really find out about diagnosis. Because medical terms is truly like a different language, as we know, that can be totally in a different component at any given time. Oops, sorry. So the first one is, can you tell me that again? Stated in words that make sense to that person. And then, can I say it back to you so that I understand what you're telling me? It takes time to do this, but it's such an important thing that we need to do, to ask these questions of the provider. So what do we do next? And how serious is this? And is there other things we should be asking? One thing I've heard so often is, I don't know what I don't know. And it's so true, in the world of medical. But a lot of times providers and specialists, et cetera, don't know either. This came from these questions, and other information came from getpalliativecare.org. The website is just fantastic. I have resources, et cetera, at the end, but I just find it very, very comforting to be able to know that there's a way that we can move forward with this. So this came from Dr. Mandrola, who is a cardiothoracic physician, that said, we in medicine are truly, they're consumers. This is a business. So what are the odds this test or medicine will benefit me? What is the downsides or harms of the test or medicine? Are there simpler or safer alternatives, not complement, but alternative options? And what happens if I do nothing? So, in combination of these two, if we can advocate, we'd never show abandonment. And this is not a burden by having these questions available for the people that we're taking care of to ask and identify. Again, they don't know what they don't know. So by having these and having them available so that we are clear and on the same page. So often when I'm in care conferences, I have found that, the providers are here, the family and the patient are here, where do we kind of get to the same point? And so many times they hear like one word and then nothing further goes on with the conversation. Health literacy is a big one. And if you compare our terminology that we use over on the left-hand side that most of us are familiar with, it doesn't match exactly, but, acute, I'm not kidding. Somebody said acute what? Acute puppy, acute, that, some people don't know what those words even mean, and everybody thinks when they're going to get better, when we talk about this, they're always going to get back to baseline. And that doesn't necessarily always happen that way. Curative, reversible, that we're going to improve to some degree, that treatable, chronic and progressive, that's going to be long-term, but how long are those type of things? Serious illness. And I've done this slide before with, it's more than just the disease. It's the burden on the patient and the caregivers that are taking care of them. And then life-threatening versus life-limiting, those kind of terms we use a lot. Terminal, there's another one. Somebody said, is that like a bus terminal? Or, and again, we interchange our terminology. And end stage, the first time they hear congestive heart failure, failure, oh my goodness, I'm going to not be here tomorrow. And then end of life. When does end of life begin? From the minute we're born, right? Nobody knows what's ahead for us. So we have to be very careful with when we use some of the terminology and what they're hearing and saying along the way with that. These are big ones, especially used at end of life, like discontinuing, withdrawing, withholding, DNR, even that, do not treat, no, that doesn't mean what it says. It says do not resuscitate. It should say allow natural death or attempt resuscitation, but we don't. We just throw these terms out there, and do not's pretty negative. So these are hard ones, like the person might feel abandoned. And, wait a second, there are things that we need to do to be able to take care of people. So these are questions that I gave some ones earlier, but these are ones that are very important that, if there are no other slides you take away today, please take this one. Do I have a serious illness or life-limiting illness? And hopefully the response isn't just yes or no. Well, more of a discussion to start that. Can it be cured? If it's not cured, or is it things to slow it down? What kind of care is available to focus on making me comfortable? It doesn't say comfort cares only. It says while you're dealing with the disease, right? What can I do to stay comfortable? If my illness keeps getting worse, when is it a good time to think about getting supportive or comfort focused care? And here's the big one that happens all the time. Will you be the one to tell me when to contact hospice? Okay. And it doesn't say enroll in hospice, it's to get information about it, whatever. But that is a big one because it's the elephant in the room. Nobody wants to be the one to start talking about that. And then the idea of, will you stay involved with my care even when I'm no longer looking for treatment for my disease? There's that abandonment one. And everybody except the surgeon, when they sign off, can still be involved. People have been able to do, if somebody's homebound, I have people, don't tell anyone, that does home visits, that can go and see this person if they aren't able to come in. They can go and see any appointment that they want because we still are working with those other things to make sure that they're comfortable, that their symptoms are well managed, that their goals of care have been discussed, we answer their questions, etc. No one should ever, ever feel abandoned from medical care, ever. And it's very, very sad because truly in my world of palliative care, it's a basic human right. And people should have the availability to be able to take care of themselves and being asking these questions. We do want to center our treatments on their patients' needs, but also their preferences. So those family questions need to come up. We use things like the Serious Illness Conversation Guide. We use things regarding that health literacy that we've talked about, as a healthcare consumer, like I talked about already. And then that we have that documentation. Are we all on the same page? Oh my gosh, fragmented and not having care coordination happens every single day. I get phone calls from people. I just recently got a phone call from somebody that just Googled North Dakota palliative care and got me. And I was just like, okay, tell me more, help me understand that. And, doing all that. So that whole coordination and transition from services, what do we do? Who's doing that transitional planning? What if, who's going to speak for me if I can't speak for myself? All these different things that need to come up. But preferences always go back to the person's need that we're taking care of. We might have our own agenda, we might have our own feelings and perceptions about things, but that's not up to us. It's for the person that we're taking care of. Very, very important to know that. I highlighted these because these are things to respond to emotion. We know that a lot of these conversations can get very emotional, and it is okay for us to cry if we need to too. But the whole idea is we want to be clear, and it takes time for doing that. Value statements, acknowledging emotions. It's such an important thing. And listen, in our world of healthcare, I think we speak, 75 to 90% of the time, and then they get their words edgewise. In fact, we sometimes overtalk them because we're already thinking ahead. But truly, it should be 50-50, if not even more based on what the person is asking us. So we need to understand who they are as a person, their goals, their values, their preferences. If you think about a person's life, the disease and healthcare may be taking a little bit more priority, but what about all the other things? Those social things of our, determinants of health. There's so many more components of that. The financial things, the other things. And it's important to listen and answer questions from the family. Again, some of them, they don't know what to ask, but now I've given you some ideas, for things for them. And it's such an important thing with the communication because some people don't want to know prognosis. Some people don't even have a clue what a diagnosis or prognosis are. And even in the world of healthcare, prognosis is what what's in the future based on what's going on. Diagnosis is what it is. And what are the options that are there? And do we ever use the term non-beneficial? Do we ever throw that in, that this is not going to be beneficial? It's available, but it doesn't mean that we necessarily have to include that with that. And that's a big emotional response. If we don't, when we say there's nothing more we can do for the disease, that's a hard one. And sometimes we just have to stop there and see where we go with that. So some of it, we do need to negotiate a little bit from that. Separate the person from the problem, so that we become a win-win-win. We really do want it to do that way. So focus on the interest rather than the positions. What's the interest here? What are we helping to do from this? We want to generate truly a variety of the options before agreeing on a course of action. Here's plan A. Well, if plan A doesn't work, what's plan B, C, D, etc. And insist that the agreement be based on objective data, not just subjective, because it's going to come out. But let's get down to basics. With the non-beneficial, is it beneficial? What's the risk, the burden, and expected outcomes? Where are we going with this? And very, very important to have those kind of conversations going on. So we need to try some new strategies. And I'm going to give you some examples here. That we need to look at the community to bring up questions and look at resources to provide for having those earlier conversations. And setting those conversations as our priority to get that opportunity to have this, the community have it. So having a groundswell approach. Here are two perfect examples. In my course of being a nurse, when I first started nursing, fathers were not allowed in the delivery room. Okay. And we're going, what? You've seen old movies where they're outside smoking, and that whole's gone away too, but smoking the cigars, proud to have the baby, etc. It took the community to start saying something like that. The more recent one, well, it's actually been a little longer than we actually think about for me, but ICU visitation. Every hour on the hour, 5 minutes, one person. When I started, that's what it was. Nothing, we have therapy dogs going in now. It's changed because we see that there's so much more we need to take care of than just focusing on the disease. There's just so many benefits of having these conversations and choosing those treatments that are the best. So I want to introduce you, if you've not seen this movie, it's called Extremis. And it was a Netflix original. It came out in 2016. It's only 24 minutes long, but it's still only available on Netflix. I've asked Dr. Zitter, she's out in Oakland, can it go anywhere else? Okay, so just have to throw in a little personal. I have a son that's in Los Angeles and is in the industry out there, okay? And he said, Mom, include these things when you're talking to people about it. It was released, it went to a film festival, etc. It's at the intersection of quantity and quality, patient-centered care in the intensive care units. Witness the wrenching emotions that accompany end-of-life decisions as doctors, patients, families in a hospital ICU face harrowing choices, okay? How are you feeling right now? It sounds pretty eerie, doesn't it? And the genres, we know documentaries. How many of you have ever seen tearjerker as a true genre? And movie is emotional, dark, and understated. Oh, I love that when I saw that. And believe it or not, in 2017, it was up for Academy Award for the best documentary short subject. It didn't win, but it was up there. And I was just like, yay, yay. So I hope I wetted your whistle, because I am going to give you a taste of it and show you the trailer for it.
Selena, can you squeeze my hand?
Here's the reality. We're all going to die. Everyone standing in this room is going to die one day. And it's good to have a little bit of a say in how.
I want to make sure that she knows that we've explored all the options.
Every day, people are attached permanently to machines. My concern is we're going to cause more suffering without likely benefit. The other approach is let her pass naturally.
It would feel like murder to pull her life support.
If I had to make the decision for myself, then take me off, and if I breathe on my own, then that's fine. That's God's will.
Amen.
How would you feel if you were not getting better on a breathing machine?
Then I don't want to be on a breathing machine.
It's his decision, but I don't want to see him go.
We're going to support you through this.
Pull the crash cart in.
wake up from this in a meaningful way.
Trauma?
Knowing at some point you got to get to that reality, and now it's here.
How many of you want to see this whole thing now? And who would you share it with and when? Can you imagine the sensitivity just in this one? I mean, I took you for a loop just on this one alone. So I'm going to introduce you to Dr. Zitter.
My name is Jessica Zitter, and I am a physician who practices both intensive care medicine and palliative care medicine. So palliative care is an approach to medicine that really looks at the whole patient and tries to account for all of the patient's needs, not just the needs of individual organ systems. Extreme Measures started out as a collection of writings from my early career when I was really suffering in the intensive care unit with no other paradigm, watching a lot of suffering of my patients. I do believe that there's a public health crisis right now with people dying badly, and I feel like I have a front row seat to it in the intensive care unit. So many people come there on what I call the end-of-life conveyor belt, and they end up attached to machines and unable to live independently. The book really became more of a vision of how we can do things differently. It is scary to talk about death. It's scary to think about death. I spend a lot of time talking to my family about death and preferences and values, and it gets a little bit less scary each time. And it's really brought us closer.
I want to go peacefully.
I'm a physician who really loves to save life, but I also have come to learn about the beauty of having a good death. A good death is really personal. Each person has their own preferences and values, and if we can match those as they're dying, that is a good death.
I've had the privilege of seeing her speak, and you saw the book that she wrote. So she followed up after the documentary that she had done with that. And this is Extreme Measures is a fantastic book. Recommend it for both lay people and for us, to really get a feel for that. So this is the book. Again, I have I disclose I don't have any financial or anything. It's a good book. It's a good read. But, we don't know what's ahead for us, and during this whole year with COVID, there's so many people that face potential and waxing and waning and all of that goes along with it. It got to be very, very difficult for people. So I just want to introduce you. I hope you appreciated that. That's kind of a little bit of my, introduction to having these conversations and how it is. So here's one case study, and I'd like to do some that I'm sure I bet you're already thinking, oh my gosh. So John, he's 75-year-old gentleman. He's got the COPD, hip pain. That's related to a long-term steroid use from it. His name was also Javier. He had both names, but he went by John when he was with us. So he had multiple hospitalizations for shortness of breath, including admissions in which he was put on a ventilator. So you can see there might have been some dialogue issues that go along with it too. So you're out to visit him in the home after a recent hospitalization, and he says, "I'm not sure I can keep going like this." And that's a hard one. Where do we go with that reply? What are the next steps that we do? And so it's very, very important to kind of go back to what's his understanding, how is he feeling, what's his preferences, all of these type of things that go along with it too. So how do you reply? Again, acknowledge the emotional subtext of his statement. I'm hearing you say this, I understand you from that. Invite him to explain more. And then truly understand where his perspective is. He might have the impression that he's giving up if he suggests changing the goals of care right now, but acknowledge this and elicit these things and say, we can have further conversations, see how you're feeling. But he says, I've had to go to the hospital many times, including twice when they put me on a mechanical breathing machine, which was miserable. Things seem like they're getting worse. And we may know this. He's not there. Remember, I'm telling you, they're on this journey and the same understanding, and not everybody jumps at that same step. Has to be little bites, little bits, pieces as we go along with that. So to respond with that, empathetically for him, acknowledge and explore, enables truly what their values are, understanding think of this as your own family member and how you go forward with that. What we find is care coordination is a big issue. That whole lack of continuity. So many people feel abandoned, especially the family members. Oh my gosh. I think I spent more than 50% of the time when I'm taking care of someone with goals of care, talking to family than I did to the patient or resident that I was working with. And there's always this complicated grief that can go along with it. And it's definitely in families that have felt that abandonment. So again, inclusion, along with permission, from the patient, et cetera, with that. And always reassure we're doing the best that we can, that they've had the best treatment. Doesn't mean that they always have to go to Mayo Clinic or do these other things if we don't see that it's going to be beneficial for them. But a lot of people say keep doing everything, and they will go to the next person and the next person and the next person that are not two things that are not able to fix them, but are also not able to, answer these questions and have these conversations that are so needed. Hospice can be recommended as a choice rather than as mandatory, which a lot of people think it's one or the other, and that they're going to take over or that they're going to be catered to. There's so many misunderstandings about hospice versus palliative care. But non-abandonment is one of the central ethical obligations of us, that nobody ever, ever, ever feels that they're being abandoned. It's such a hard part of where a person can be with all of that. This is a really good book by Dr. Byock, and I often do this if I have a family, a patient, and I'm working with a family where I feel that I may not see this person again, or that they are not doing well. And I do it with a lot of closures. And so forgiveness, forgive me if I have not addressed all your questions, etc. I forgive you. I understand your anger, and I understand that, and that's fine. Thank you. This has been, the gratitude component of it. It has been such a pleasure and an option to be able to work with you and love you. I care very much about you. So even though we don't always give people these abilities to say these foreclosure things, and sometimes we need to assist the family with doing it as well. Whether or not it's timely, it starts them with the process that, these are things that matter most. And Dr. Ira Byock, who's actually from Montana originally, I've met him on several occasions as well, too, which is from conferences and things. But he says the last one then is the goodbye. And so many people never get to the goodbye. They don't want to, but these 4 other ones, there's some way that, that we are able to express them. And even though we can't fix the disease, that personhood needs to occur. And so the forgiveness, the gratitude, and the caring, we never, ever should abandon those for anybody we take care of. So the thing I've heard before, it feels like murder. I've heard that over and over again. If it was me, I would, different things like that. It's variations we don't have very often. And the whole idea of overtreatment helps every day. Can someone give me an example of something that you thought was like, why are we doing this? Or this is too much, or the benefit is going to not be there. The burden is much more than the benefit.
Yeah, this is Nicole. I just think about that patient that's in their 90s that, now requiring dialysis, and they have other multiple medical issues going on. And obviously, it is the patient's choice to decide, some of those difficult things, but to not even have that conversation about somebody to sit down with you and say, this is where we're at, this is everything going on, given this new choice that we need to make, where would you be, where would you want to continue, or what would you want to do with that? I think sometimes that gets kind of frustrating when, the only option is to do dialysis, and that's
I had a 90-year-old with dementia that they were thinking about opting to do that. And I'm going to give you the example. One week I was taking care of 3 people. They all were going to be offered dialysis and 3 different things. And all 3 of them responded to me, I'm doing it for my family. Have you ever heard that one too? Where I'm doing it for my family. So the first person was in her 70s and was going to do outpatient dialysis and be able to come in and out and do that. And she had family support. And I followed her for about 6 months, and she thrived. She did very well. The second person died of complications of dialysis within the first 10 days. And the third one was a gentleman, tried it for 1 week, said, no way, Jose, this was not his lifestyle. So do we do a time limited trial versus doing all of that kind of thing? And the fact that, the dialysis is a perfect example, because here in rural North Dakota, we don't have dialysis everywhere. And people have to travel 120, 150 miles to come for a dialysis treatment, and it's 3 times a week, and part one. The other one is CPR, right? How many people are offered attempt CPR? We can't guarantee it, right? And what are the outcomes? Have any of you witnessed CPR and seen the outcome usually is not very good? And the statistics, if you look at it, we actually have, both in the hospital and the nursing home, and that statistically, depending on what their underlying cause is, what brought on the cardiac arrest, people get, that's the other one too, they get heart attack versus cardiac arrest confused, that they don't know the difference between those two. So lots of education, awareness and education is such a big thing. But, the ultimate outcome, are they even going to survive to leave the hospital? And pretty much will not get back to their baseline. Would you recommend bringing families in to watch CPR?
On the one hand, do you think, it's important for them to see like how traumatic this truly is, and really it's not like you said, like it is on TV, because I think that's a lot of people's only experience with CPR, just a few taps on the chest and you're awake. But on the other hand, gosh, it's such a traumatic experience. I mean, as healthcare providers, to see it when it's someone we don't know personally and love, and that's traumatic enough, so to have a family member see their loved one go through that, I mean, that's hard to get over. So I guess I'm mixed.
Yep. And that's what we do. We pull in the staff, the chaplain, everybody should be there, because it's taking all of us, to make these decisions and stuff, versus the closed wall where you go out and give reports and they say, well, keep doing everything, and they don't see what's.
And of course, code status is something that could be talked about for days.
Mm-hmm.
But I think it's so important to talk about it, because I've worked with so many different providers, and I've seen it explained really, really great and not so great. And so I think that, that communication, the discussion is important. I've had providers that just say, do you want everything done or not? And that's not the way to discuss it.
Oh, a lot of that.
And as a social worker, I'm our palliative care social worker here. I mean, I can do my best, but it's, I also can't write the order for a code status. But so I just think this is such an important thing for everyone in the healthcare team to learn the skills to be able to really have
an experience with the intubation discussion or tracheostomy discussions.
Think about the trach conversation. It often goes with the peg. Are we going to trach and peg? That's always
that's for our next one. We're going to get to that one next.
So, especially with our patients, a lot of times when I see in the ICU, and I think it's unfortunate because I don't think that it's always a great conversation, kind of like the code status thing. It's like, well, if you want to keep trying, if you want to keep treating, we'll just do a trach and peg. There isn't necessarily the conversation regarding what does that mean? What does this mean for the long-term outlook? And what if this doesn't work?
Yeah.
I think time and time again, we have folks that get the trach and peg, and then, the next week they're consulting, hospice because it doesn't work. And then the family's got that regret almost, or that grief or guilt. We shouldn't have put them through that if this was the outcome, so, and I think some families have the perception that if we do this, we're not going to be looking at end of life. And so they don't get that full picture that this may not work. And we still may be looking.
It's called Hard Choices for Loving People. It's by Hank Dunn. He's a chaplain. He's actually works from a nursing home in North Carolina. And he talks about very neutral value, but everything from CPR, intubate about is the feeding tube. You know, the benefit of it versus, is this considered ordinary versus extraordinary versus beneficial, non-beneficial, all of these. And especially from, because we're including faith-based from here, we're talking about, you know, all these things, because everything that we do is always taken care of, and nurturing and nourishment seem to go hand in hand, right? Every event that we have. And so stopping that, how do families respond to that when we're starting to have the feeding tube discussions, or the patient themselves, if they're capable of talking? Where do we go with that as far as not feeling abandoned, and not overtreatment, you know, kind of that, where do we go? What are you hearing for people?
You know, of course, with the idea of food and getting nutrition, of course I don't want my loved one to starve.
Yeah, you're starving my loved one. That's the
Yes.
word we hear. Let's starving them.
That's, you know, when they've got that mindset, that's hard to get them to think of it.
You know, time limited trial is a big one. When in doubt, I often will offer that if it doesn't work, because you can only insert, for those of you, if you don't know, the peg tube, you know, the ones that go into the stomach, after it gets long term, we don't stay with the nose or mouth anymore. And you can only put in a new tube so many times, because you know, the peritoneal and some of the other things that are there. So if you can't get into that same socket, you're more at risk of causing more harm than good. And so then you might need to go back to the nose, and they're going, oh my goodness, you know. So there's lots to talk about, you know, long-term versus short-term, and doing with that. Oh, perfect. You know, referring to the Alzheimer's Association, the residents established, you know, a trach as the line we didn't have to cross. That's a great one. I've heard that one many times. But again, the one benefit with the trach is that it doesn't have to be permanent. It is a time where that you can talk to that person and, you know, have some understanding and make decisions from there. And you can remove a trach, right? And the person's still able to breathe if they're not hooked to the ventilator that goes along. And the one thing that I find that's very hard, especially with artificial hydration nutrition, which is never ever considered, you know, it's not an ethical thing for us to withhold it or stop it if the family is, or our patient has decided that, even though it might feel uncomfortable for us. But people's own opinion, like, oh, I wouldn't, or I should. It's not ours. It's not ours, you know, that we have to support the patient and the family and always advocate for them. Oh, so we can get into the whole advanced care plan situation. You know, does it apply? Is it appropriate for right now for where that person is, depending on where their situation is? And have we referred to it to see if it's in the same ball? The best job with having these kind of conversations? Is it primary care? Is it a specialist? Who are you finding are your advocates and your palliative, not the experts, but the ones that truly support having these more hard conversations? Who are you finding in your facilities or working with?
Well, in my setting, you know, I'm only working in the inpatient setting, you know, so I mean, I would imagine that the primary care providers, the ones who have known patients the longest and have built that trust with their patients, I feel like that would be a good place to have them, ideally, of course. But here in the hospital setting, it's a time of crisis, and things have changed so much that since they've been with their primary care provider last. I mean, so my greatest partners in these types of goals of care conversation have been, you know, some of the hospitalists, you know, internal medicine providers. They've also been my least helpful. You know, it all depends on the provider and where their passion lies. But I have got some amazing providers that are just so committed, you know, and will sit down and take this time. And gosh, there's nothing better, you know, than a beautiful, good goals of care conversation, you know, with a family and their loved one and a good provider. But it's you never know what you're going to get.
Exactly. And so many times I'd like to record them so
Absolutely.
someone else can listen and learn from their skills on how well they can do that and things. And a lot of times it is the hospitalist that comes in from kind of an objective perspective because they don't know this person from the external. But if they could work with the primary, the one problem we find with the primary care, the PCP, is that sometimes that their relationship is so close that they don't want that person to lose hope, and that they have that sense of being a little bit more sensitive to those kind of needs and doing it gently, like, well, let's just do everything and see what happens kind of thing. I have seen that happen too, but again, there are those people that just do such an excellent job. How about others?